Hello, all of you. Warm welcome to the FMG Spotlight session. I'm Dr. Jazeer Abdul Khader, your dermatology faculty at PW MedEd. So I hope my video is visible to all of you. So please let me know if there is no technical issue like a video or a voice issue. Thank you so much. Please let me know in the chat box. Just a minute. We'll just get it started. I can't find your messages. Yeah, now it is fine. So Moideen Subair, Dr. Patel, all of you, yeah, very warm welcome. So very few days left for your FMG exam, and I hope that all of your preparations are going fine, isn't it? So our plan today is we have already started the FMG Spotlight. Multiple subjects has already been covered at PW MedEd. So today I would be driving you through the entire dermatology, all very important questions and important topics. I have just curated around 20 to 25 MCQs, just making sure that everything that is most important will be covered today. So is that all fine? So if that is all good, so we will just get it started. So let's begin with the first MCQ of the day. Okay? So the first MCQ is a 35-year-old male presents with a well-demarcated, slightly scaly, reddish brown patches in the groin area. He reports that the patches has been present for several weeks and are mildly itchy. He has no significant medical history and takes no medication. On examination, patches have a coral red fluorescence under Wood's lamp. So which of the following is the most likely diagnosis? So what is the issue is that if you are getting such very long questions for your exam, what do you think? Long questions are difficult or easy? So when you get such long questions, you have to go through the entire question and try to pick out the most important key points out of it. Okay? So in this MCQ, what do you think is the most important key point? So the easiest key point I would say is that the patches have a coral red fluorescence under the Wood's lamp. So in which disease did we learn that there can be a coral red fluorescence under a Wood's lamp? Anyone? Anyone who is attending the lecture right now, can you give me an answer? Where do you find a coral red fluorescence? Yes, the coral red fluorescence can be seen in this condition called as erythrasma. It is seen in erythrasma. So whenever you get such a question, always try to go for the keywords. Now, what are the points that is actually going to be in favor of erythrasma? So here it is like there is a scaly lesion. There are brown patches, matlab hyperpigmented lesions. And where is it present? It is present in the groin area. So remember, erythrasma can always be seen, usually over the axilla, or it can be seen over the inguinal area. Okay? It can be seen over the inguinal area. So these are the two places where you can find a erythrasma. Okay? And what is erythrasma? Erythrasma, is it a bacterial infection, fungal infection, or a viral infection, or anything else? So this erythrasma is going to be a bacterial infection. So this bacterial infection called erythrasma, So what is the bacteria that causes this infection? The bacteria that causes this infection is, any guess? Bacteria that causes erythrasma? That is called as Corynebacterium. It is called as Corynebacterium. So this Corynebacterium, when you do this examination called a Wood's lamp examination, you will be able to get a colored fluorescence. And the colored fluorescence that you can find here in this case is called as coral red fluorescence. So based on all these things, the right answer would be Corynebacterium. Now, why did I give you such a question is because you have to remember the various dermatological investigations. Now, in the investigations, this is a very important investigation called Wood's lamp. It is called as Wood's lamp. So this Wood's lamp, it is a small instrument where you turn on the instrument and you are trying to look at the fluorescence from the diseased skin. Now, what is the wavelength of this instrument? The wavelength, if you remember, the wavelength of a Woods lamp is 365 nanometer. 365 nanometer is going to be the wavelength of a Woods lamp. Now, please remember, for your exam, please try to memorize this table before you go for the exam. Okay, so these are the important Woods lamp findings that you can see in all the diseases. Like in tinea capitis, you can see a greenish or a yellowish fluorescence. Erythrasma, we can see a coral red fluorescence. Pseudomonas, तो easy है, isn't it? क्योंकि जब भी हम pseudomonas कहेंगे, what comes to our mind? Green color. So in the Woods lamp also, you will be able to see a greenish fluorescence. जैसे vitiligo. Vitiligo में what is the color of the skin? Deep pigmented, white color. So Woods lamp examination में you will be able to see a whitish fluorescence. Now make a point of this one, that is Porphyria cutanea tarda. So in Porphyria cutanea tarda, what happens? So here we are not using the skin to take out the fluorescence. Instead, you can see this pink color or orange color from the urine. So please remember, on the day of the exam, if you are getting an image of a urine sample from which the Woods lamp is going to reflect a pinkish color or an orange colored fluorescence, then the answer is going to be Porphyria cutanea tarda. But in other conditions like melasma, the skin may appear more darker than the adjacent skin. So in tinea versicolor, it is also important finding. In tinea versicolor, we may get a yellow or a golden color type of a fluorescence. And lastly, Propionibacterium acne. Now, what is the disease which is implicated by Propionibacterium acne? The name itself says, isn't it? That is going to be, yes, very good. That is going to be acne vulgaris. So in acne vulgaris also, you can find a orange or a red colored fluorescence in case the organism is going to be Propionibacterium acne. So these are the very important points that I would like to emphasize. Now in this first slide, before we go further, can you tell me what is the KOH result of a tinea versicolor? So tinea versicolor, that is also called as pityriasis versicolor. What is the KOH finding? So this is also important for you. I just want to cover it as we move. So in pityriasis versicolor, the KOH finding is going to be, so any guess? Yes, that is going to be meatballs, isn't it? Spaghetti and meatballs appearance. Spaghetti and meatballs appearance. So spaghetti and meatballs, banana and grapes appearance. So all these things is seen with pityriasis versicolor or tinea versicolor. It is also called as tinea versicolor. So shall we move to the next question? So with your permission, I'm just going to the next one. So now let's see what is this question. Again, long question. Okay? So in long question, just try to train your mind. All these are clinical based questions. So clinical case discussions. So a 72-year-old female presents with a 6-month history of itchy tense blister on her trunk and limbs. The blisters are large and are filled with clear fluid, and some has eroded to form crust. She has no significant mucosal involvement. So which of the following DIF finding is most consistent with the diagnosis of bullous pemphigoid? See, from this question, what I would like to emphasize here is the entire first part of the question has zero relevance. Did you understand that there is zero relevance? Because what are they asking? Which of the following DIF finding is consistent with bullous pemphigoid? That's it. Okay, so the initial part of the question is just to make you engaged, waste your time, isn't it? So yeah, you should be sharp enough to understand that the examiner is asking bullous pemphigoid mein what is the DIF finding. That's it. So just before we go into the options, let us try to memorize what was happening in bullous pemphigoid, isn't it? So we learned about pemphigus vulgaris. We learned about pemphigus foliaceus. Also, we learned about bullous pemphigoid. So in all these things, remember the major difference is going to be in pemphigus vulgaris as well as in pemphigus foliaceus. What is the defect? The defect is in a desmoglein. So there is a desmoglein defect, isn't it? So it can be desmoglein 3, it can be desmoglein 1. And where is desmoglein present? Desmoglein is present within the epidermis. So there is a intraepidermal defect. Whereas, what is a defect when it comes to bullous pemphigoid? In bullous pemphigoid, the defect is going to be in hemidesmosomes. And where is hemidesmosomes present? Is it present inside the epidermis or is it present below the epidermis? Yes, it is present below the epidermis. Now, what comes below epidermis? So below epidermis, you have something called as a basement membrane zone or dermoepidermal junction or dermoepidermal junction. So what happens with this investigation, which is called as the direct immunofluorescence, is that in all the cases of vesiculobullous diseases, जैसे pemphigus vulgaris हो, pemphigus foliaceus हो या फिर bullous pemphigoid हो, in all these cases what do is that in vesiculobullous disease we do a direct immunofluorescence from the perilesional skin. Perilesional skin. So that is the important point here. And in perilesional skin, if you do a direct immunofluorescence, what do you find? You can find either there is a IgG or C3 deposit. If there is a defect within the epidermis, you can get a fishnet pattern or a chicken wire pattern, isn't it? So if there is a defect below the epidermis, that is in basement membrane zone, you can find a linear pattern. So now let's go back to the MCQ. Now you tell me what is the right answer here. First one says IgG and C3 along dermoepidermal junction in a granular pattern. Correct or wrong? It's not granular, isn't it? Next one, IgA deposition. Is it IgA? No, it is going to be IgG and C3. So the next one says IgG and C3. IgG and C3, this is right. Dermoepidermal junction, that is also right. In a linear pattern, this is also right. So what's the right answer? It is going to be option C, that is IgG and C3 deposition along the dermoepidermal junction in a linear pattern is what you see when it comes to bullous pemphigoid. Now, all of you who are right now watching this video, please let me know what is the most important DIF finding that you can find in pemphigus vulgaris. So please remember, in pemphigus vulgaris, you can see IgG and C3 in the epidermis. And what is the pattern? In a fishnet pattern. Very good, Muhiddin. In a fishnet pattern. In a fishnet pattern or a chicken wire pattern. So for your exam, once again, I have formulated a table so that you have all the findings together. So please try to remember this table as well. So this is a very important table for you. That is the all of the DIF findings. Pemphigus vulgaris mein we have the fishnet pattern or the chicken wire pattern. In bullous pemphigoid, IgG and C3 deposited linearly over the basement membrane zone. In dermatitis herpetiformis, remember dermatitis herpetiformis? In dermatitis herpetiformis, we get granular IgA at the dermal papilla. In SLE, that is systemic lupus erythematosus, what can you find? At least try to remember in this last moment that in the direct immunofluorescence in the SLE, you can find a lupus band. So you can find a lupus band. Very, very important. Lupus band direct immunofluorescence finding in systemic lupus erythematosus. And last one is linear IgA disease. सबसे easy है ना? Why is it easy? लीनियर IgA डिजीज में क्या होता है DIF फाइंडिंग? Linearly, IgA is deposited over the basement membrane zone or dermoepidermal junction. So that's it. So that is all about the DIF findings in various vesiculobullous diseases. So please make sure that you learn this table. After this live session, we are going to share the same annotated PDF in the PW Telegram group. So make sure you download it and revise the entire DIF findings. Okay? So now let's go to the next one. A 10-year-old child presents with a linear walled skin rash. The rash is non-itchy and has been present since birth. So I'm just trying to pick up the most important things as we go. Okay, there is a rash which is present since birth in a baby. And how does this rash look like? It looks linear and it has a walled skin type. है ना? So, the pattern of the rash is distinctive and follows a specific line. So here they are trying to hint that there is a peculiarity about the skin lesion. Like there is a peculiar pattern of the rash and it is following some lines. Remember, some lines. So identify the skin pattern in the given image. So what is this? So you can see that this is the umbilicus of the patient, and then the rash is present in something like this. So in which type of lines are being represented here in this image? So is it a dermatomal fashion? So dermatomal means along the nerve root, correct? Langer's line, which we have learned that these are important surgical lines. So is it Blaschko's lines or is it Koebner's phenomenon? What is your right answer? Please try to give an answer in the chat box. I just wanted to know. ये थोड़ा twisted question है, but still if you are able to make out the right answer, then you are very much in track. So just give it a try. No issues even if you go wrong. So C says Mohiddin. Very good, Mohiddin. Excellent. So happy to know that you are able to answer it. This is going to be Blaschko's lines. Excellent. Okay, it is going to be Blaschko's lines. Now let us see what are Blaschko's lines. So remember, if there is a question about the skin lines in the MCQ, so most likely they can ask you either the first one. The first one is called as Blaschko lines. Okay? And the second one that is of very important surgical importance. What is it? This is going to be called as Langer's lines. This is called as Langer's lines. So Blaschko and Langer's दोनों important है because in the last NEET PG exam they asked you about Langer's lines. So Langer's line का question आ रहा है, तो what is the question that is expected? Then they may tell you that these are important surgical lines. Okay, these are important surgical lines because we always would like to give an incision that is parallel to the Langer's line so that the wound heals faster with less of scarring. That is it. Now, when it comes to Blaschko's lines, there are multiple diseases where you can find Blaschko's lines. Some diseases, they follow the Blaschko lines. So remember, what are those diseases? The diseases are going to be HIE. So remember it as HIE, H for hypomelanosis of ito, I for incontinentia pigmenti, and E is for epidermal nevus. E is for epidermal nevus. So in this MCQ that was asked, where the lesion was present since birth, so this is more likely that it can be an epidermal nevus which is present since birth. So it becomes prominent at some point of time, and this is following a certain line. And what is the line? The line is Blaschko lines. Okay, all good. So now let us go to the next question. A 45-year-old woman presents with a pruritic erythematous and vesicular rash on her wrist and hands that started a few days ago. Now she reports recently starting to wear a new watch. Patch testing reveals a positive reaction to nickel sulfate. Based on the patient's history and test results, which of the following is the most likely diagnosis? Atopic dermatitis, psoriasis, allergic contact dermatitis, irritant contact dermatitis. So can I have your answers, please? So what is the right answer here? Easy question hai. So you can just go through the question. Somebody, a lady is having pruritus, means itching and some rash. And how did this rash start? It started few days ago. And what is new here? She started to wear a new watch. So somebody wears a watch and after wearing the watch, they are getting a rash. So is it allergic contact dermatitis or is it irritant contact dermatitis? What is the right answer? Easy question. Yeah. So this is also again going to be C, that is allergic contact dermatitis. Now here it says nickel. Why? Because nickel is going to be the most common metal that causes allergic contact dermatitis. So in allergic contact dermatitis mein, what is our investigation of choice? So the investigation of choice is given in this MCQ itself. तो इस पेशेंट का क्या किया था? इस पेशेंट का पैच टेस्टिंग किया था, isn't it? So patch testing. So patch test is going to be the investigation of choice when it comes to allergic contact dermatitis. So just for your information, let me show you an image of the patch test so that on the day of exam, if you get an image like this, where over the upper back of the patient, something is being stick to the upper back. So there are multiple chambers within this patch and this is called as a patch test. So in patch test, when is the reading taken? Because we are going to stick this over the back of the patient. We'll ask the patient to go back home and come back after 2 days or 4 days or both. So the first reading and the usual reading in the OPDs, they are taken after 48 hours. But for the sake of MCQs, we will go for the best reading with the maximum delay. Okay, so the best reading is taken at 96 hours. So first reading at 48 hours and the best reading at 96 hours. This is all done for patch test, which is the investigation of choice for allergic contact dermatitis. And remember, everything which can cause a skin allergy after a contact for several days is most likely to be allergic contact dermatitis. So everything is going to be allergic contact dermatitis except, now what are the exceptions? Because I think it is better to remember it in this way. जो भी है सब कुछ allergic contact dermatitis है. But what is going to be ICD? So except detergents, dishwash and organic solvents. Okay, so on the day of the exam, if the question says the patient has been using hand sanitizers, got dryness of the hands, what is the answer? Irritant contact dermatitis. So all these are going to be irritant contact dermatitis. Irritant contact dermatitis. Okay? Everything else, let it be Parthenium hysterophorus. It was once asked for your FMGE exam, like the most common plant causing allergic contact dermatitis. What is the name of the plant? The name of the plant is Parthenium hysterophorus, which is also called as the Congress weed. So this is the most common cause of allergic contact dermatitis, also the most common plant causing allergic contact dermatitis, and everything else is going to be ICD. Everything matlab just detergents, dishwash, organic solvents. Okay? So that is about ACD and ICD. So now let's move to the next question. A 3-year-old child is brought to the clinic by his parents due to a persistent itchy rash. Due to a persistent itchy rash. The parents report that the rash has been recurrent since the child was 6 months old, mainly affecting the skin in the elbow and the knee creases. On examination, the affected area shows red, scaly and lichenified plaques. The child also has a history of asthma. Which of the following is a likely diagnosis? So all these things, I'm just trying to add more and more long questions so that you just go through the question fast, try to pick up the key points. Now, यहाँ पे, whenever you get these kind of long questions, so dear students, make sure that you are keeping one point in your mind, that is the age. So what is the age here? The age here is 3-year-old child. So this child is having a itchy rash. Now, there has been multiple recurrence of this rash since 6 months old. So 6 months se leke 3 years tak, there is a recurrence of symptoms in this child. And now, where do you find the rash? You can find the rash over the elbow as well as the knee creases, which means this is all going to be over the flexures. So you're going to see these over the flexural surfaces. And importantly, the question also says that the child is also having a history of asthma. So child is having a history of asthma. So which is that chronic skin condition which causes itchiness over the skin, and there is a history of atopy, means allergy, जैसे bronchial asthma, hay fever, etc., allergic rhinitis, etc. So what is the diagnosis? Any guess? So is it A, B, C, or D? Seborrheic dermatitis, atopic dermatitis, contact dermatitis, psoriasis. So definitely not psoriasis, isn't it? It's a 3-year-old child. Contact dermatitis, यहाँ पे कुछ contact का history है ही नहीं. So this is not contact dermatitis. So now last we are in between seborrheic and atopic dermatitis. What is seborrheic dermatitis? The usual dandruff that we have, isn't it? So not seborrheic dermatitis. So history is going to be consistent with atopic dermatitis. It is going to be consistent with atopic dermatitis. So very good. That's corner is answering. So again, the next important table for you. The atopic dermatitis is again a repeat question in NEET PG. So be prepared for FMGE for a question on atopic dermatitis. Okay? Atopic dermatitis ka every question they will always tell you where is a skin rash and if there is a family history or a personal history of atopy. Okay? Now the important point that you're going to check here is in atopic dermatitis, if the age is in between 0 to 2 years, matlab from birth up to 2 years, the rash, it is usually crawling babies, correct? So in crawling babies, where do you find the rash? You may be finding this rash over the extensor surfaces as well as over the face. So remember, face and extensor surface at birth up to 2 years. Now after 2 years, don't read the entire sentence now. After 2 years, like in children as well as in adults, where do you find the rash? The rash can be typically seen over the flexures. So both these things, remember it as flexures. So this flexural area is going to be the most common area where you find a rash after 2 years up to adolescents and even adults. Okay? But only at birth up to 2 years, where do you find? Over the extensor surface. That is all about atopic dermatitis. So now let's go to the next question. The next question is, a patient presented with a well demarcated erythematous plaques covered with silvery scales on the elbow and knees. The patient has a 10-year history of psoriasis along with nail changes. Considering the chronic nature and the extent of the patient's psoriasis, which of the following treatment option is most appropriate? Now see how the question has been framed. So we know that while we were learning about psoriasis, how did you learn about psoriasis? We learned that in psoriasis mein kya hota hai? The patient is having a erythematous plaque. That is the most common presentation. And this erythematous plaque is going to have some scaling. Now what is the type of scaling? Silvery white scales. And where do you find these lesions? You find these lesions over the extensor surfaces. That is the typical presentation of this disease called psoriasis. So dear students, any question on psoriasis. Very, very, very important topic. Psoriasis is always asked. Remember, you are going to see a red colored plaque with a silvery white scale, usually over the extensor surfaces. Now, in this question, they're asking you what is the most appropriate treatment, showing that there is a chronicity of the symptoms. Okay? So there is a patient with psoriasis along with nail changes here. What do you think is the answer? Would you like to go for a high potency topical corticosteroids? Topical steroids matlab steroid creams. Or would you like to go for oral antihistamines like cetirizine, loratadine, etc.? Or systemic biological therapy or topical antifungal? Easily क्या rule out कर सकते हैं? This is, psoriasis is not a fungal infection, right? So definitely not antifungal creams. So what else? Is it a very itchy condition? Again, not an itchy condition. So let us rule out oral antihistamines. Now you are left with steroid creams and biological therapy. So remember here, very good. So here the right answer would be biological therapy. So we know that overall in psoriasis, remember the treatment part of psoriasis. In psoriasis, the overall drug of choice is going to be methotrexate. So the overall drug of choice is going to be methotrexate. But when it comes to pustular psoriasis, what is our drug of choice? Our drug of choice is going to be acitretin. It is a retinoid. It is a retinoid. That is in pustular psoriasis, the drug of choice is going to be acitretin. When it comes to psoriasis in pregnancy, psoriasis in pregnancy. So what is our drug of choice in psoriasis in pregnancy? We cannot give methotrexate. We cannot give acitretin because these are going to be teratogenic, isn't it? So here our drug of choice is going to be steroids. So our drug of choice is going to be oral steroids when it comes to pregnancy. So these are the different drug of choice. But recently, remember that even methotrexate, it cannot be used in patients who are having some liver disease, etc. So here, in chronic cases, it is very much preferred, and recently one of the top first line agent of choice is going to be biological agents. Okay, biological agents. So all those monoclonal antibodies, etc., that we use are all going to be used as a biological agent in the treatment of psoriasis. And remember, this very important point that oral steroids are contraindicated in psoriasis. I hope you remember this point. Oral steroids are contraindicated in psoriasis. So please, if there is an option like prednisolone, do not jump into that option. Okay? Oral steroids are contraindicated in psoriasis. And what is the only situation or only condition where we use steroids in psoriasis? That is while in pregnancy. That is while in pregnancy. So that is about psoriasis. So now let's see the next question. A patient with a history of psoriasis presents with a asymmetric joint pain and dactylitis. Radiographic findings include pencil in cup deformity and periostitis. Which condition is most likely associated with these findings? Rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, reactive arthritis. Can you make any guess for this question? Now the question itself says, see, if you are having a good presence of your mind on the day of the exam, you will definitely get these kind of questions where the answer is already hidden in the question itself. So if you just read the question already says what is the diagnosis in the patient. This is a patient of psoriasis. So a patient of psoriasis is getting joint pains. What should it be? It should be obviously psoriatic arthritis. Should be obviously psoriatic arthritis, because you must have learned about many of the radiological findings in psoriasis, isn't it? Like the pencil and cup deformity, ivory phalanx, isn't it? So all these things can be seen. And this one, this topic called psoriatic arthritis. In the last FMG exam, there was at least 2 questions from the same topic from psoriatic arthritis. So in psoriatic arthritis, what is usually having, what is the most common joint that is involved in psoriatic arthritis? The most common joint that is involved in psoriatic arthritis is going to be distal interphalangeal joint. Okay, DIP, distal interphalangeal joint. But what is the most common type of psoriatic arthritis? The most common type of psoriatic arthritis is going to be asymmetric oligoarthritis. Asymmetric oligoarthritis. So why do I call it as asymmetric oligoarthritis? If a patient all of a sudden complains that I'm having a severe knee pain only on my left knee, so that is going to be oligoarthritis. Only one joint is involved and it is going to be asymmetric. It is going to be asymmetric. That is the most common type of psoriatic arthritis. Okay, so that is all about psoriatic arthritis. So please remember, the treatment when it comes to any patient who is having psoriasis along with psoriatic arthritis is again going to be methotrexate. And please remember the important radiological findings. The one of the important radiological finding is given in this MCQ, that is penicillin cup deformity. So along with penicillin cup deformity, you can also see ivory phalanx, which is also a very important findings that you can see in the X-ray, isn't it? So all these are findings that is consistent with psoriatic arthritis. So with your permission, I'm just moving to the next question. So let's see, a 50-year-old female presents with complaints of painful lesions in her mouth and changes in her fingernails. On examination, you observe white lacy patches on the buccal mucosa and longitudinal ridging and thinning of the nails. Which of the following is the most likely diagnosis? So what do you think is the most likely diagnosis? It is a female patient. Okay, many of you are saying A. So just try to think once again whether it is A or something else. Okay, it's a female. There is some painful lesion in the mouth and there is some changes in the fingernails. Now what are these changes? Within the oral cavity, you can see white lacy patches, white lacy reticulate patches. And what are the changes that you see over the nails? You can see that there are longitudinal ridging. So these are longitudinal ridging that you can see over the nails. So what is now the most important finding? And importantly, there is a thinning of the nails as well. Thinning of the nails. Now, is it A, B, C or D? Yes, very good. So this is going to be lichen planus. Okay, this is going to be lichen planus. So this white lacy patches, they are called as Wickham's striae. So the white lacy patches that you can see are called as Wickham's striae. Okay, and what are the nail findings in lichen planus? So the nail findings in lichen planus, the most common is going to be thinning of the nails. So along with thinning of the nails, what can you see? You can see something like this. So what is this finding that you can see in lichen planus? Yeah, Mohiddin is again answering it right. This finding is called as pterygium of the nails. An important image-based question. It is called as pterygium of the nails. Now in lichen planus, the most important thing that you will try to remember is the color of the lesions. So these are going to be plaque lesions. And what is the color? Do we call it as erythematous plaque lesions? Absolutely no. So this is going to be called as violaceous or violet color lesions. Violaceous or violet or purple colored lesions. Okay, this can be called as purple colored. So for your MCQ, whenever you are finding this kind of a purple colored plaque lesion, or if the MCQ says purple colored skin rash, please think about lichen planus. And this is a very important image which has already been asked for your exam. So whenever you get this white lacy reticulate pattern within the oral mucosa, so this is called as 𝐌𝐞𝐝 striae within the oral mucosa. Now what is the importance of this? This is a pre-malignant lesion. So this is a pre-malignant lesion. Pre-malignant lesion in the sense this is going to be pre-malignant to which type of cancer? Is it basal cell carcinoma, malignant melanoma, or something else? Yes, this is going to be pre-malignant to squamous cell carcinoma. Squamous cell carcinoma. So please make sure that you do not forget. Now, in the beginning, why did somebody tell me in the chat box that this is going to be oral candidiasis? See, oral candidiasis may what happens? There is definitely a whitish patch lesion that develops, isn't it? There is a pseudo membrane that develops over the oral mucosa. And which type of patients develop oral candidiasis? It can be either immunocompromised patients, isn't it? Or the patients who are using inhalational steroids, isn't it, for the treatment of bronchial asthma. So whoever uses inhalational steroids for bronchial asthma, they can also develop oral candidiasis. So that is all about this question. So now let's move to the next one. So a patient presents with a pruritic purple polygonal papules on the wrist and the oral mucosa. Now, abhi, I told you, whenever you see purple colored papules, what should come to your mind? The answer that should come to your mind is going to be lichen planus, correct? But let us not be too enthusiastic. Let us just read it with caution. The purple colored papules are there on the wrist and there is something on the oral mucosa. We have done a skin biopsy. So which of the following histopathological findings is most likely to be observed? Chalo. Now we will keep that lichen planus is our provisional diagnosis, and let us read all the options to make sure that any option is there which is consistent with the findings in lichen planus. First one, acanthosis with elongation of the rete ridges and Monro micro abscess. So in which disease did we learn about it? So there is a elongation of the rete ridges, something like this, which we can call as camel foot rete. Camel foot rete. And this very important finding of Monro micro abscess. Now, where do we find them? We find them all in psoriasis. But our differential diagnosis for this case was lichen planus. So this is not the right answer. Let's go to the next one. Band-like lymphocytic infiltration at the dermoepidermal junction with civetty bodies. Third one is parakeratosis in the absence of granular layer. Fourth one is spongiosis and eosinophilic infiltration. Where do you find spongiosis? Spongiosis is the hallmark of what? It can be seen in eczema, isn't it? Acute eczema. Parakeratosis can be seen in multiple cases, but here in this case of parakeratosis and the absence of granular layer, this is more likely to be in psoriasis. So what is the right answer? The right answer is option B. That is band-like lymphocytic infiltration at the dermoepidermal junction with civetty bodies. So this is going to be a typical finding that you can see in the histopathology of lichen planus. So in the histopathology, remember two diseases. One is lichen planus and the other one is going to be psoriasis. Now in psoriasis, what are the important histopathology finding? One important finding, I mean 2-3 findings are given in this MCQ itself. One is that you can find parakeratosis. The other finding is that you can find a micro abscess. And what type of micro abscess is seen in psoriasis? Very important. It is neutrophilic micro abscess. And neutrophilic micro abscess, they are of two different types in psoriasis. Very important one, repeatedly asked. Now, what are the neutrophilic micro abscess that you can see in psoriasis? One is Monro micro abscess and the other one is Kogoge spongiform pustules. Kogoge spongiform pustules. So please make sure that you remember this point. Very, very important point for your exam. The neutrophilic microabscess that you can see in psoriasis are two Monro's microabscess and Kogoge spongiform pustules. So moving to the next one. A patient with a well demarcated depigmented patches on the hands and the face. Patient has no other skin complaints but has a history of thyroid disease. Which of the following autoimmune disease is most commonly associated? Let's see what is the right answer. Any other guess? See, from this image, what is the diagnosis? So from the image that is given, you can see a well demarcated whitish depigmented lesion. Correct? So this well demarcated whitish depigmented lesion can be seen in a condition called as vitiligo. Hana? So in vitiligo, what is vitiligo? Vitiligo is a autoimmune disease. So our body is attacking our own melanocyte, because of which the skin becomes depigmented. There is a complete absence of melanocyte. So every autoimmune disease, they tend to occur together. Like alopecia areata can be seen in vitiligo patients, and vitiligo patients can also have another autoimmune disease of the thyroid. What is the name of this autoimmune disease of thyroid? Yes, it is called as Hashimoto thyroiditis. So the concept that is being asked here is autoimmune diseases, they tend to occur together. Okay? So vitiligo, alopecia areata, Hashimoto thyroiditis, all of these things can occur together. Now, in once in for your FMG exam, they have given you a depigmented lesion not crossing the midline over the neck area. Now, यहाँ पे I'm giving you another lesion which is not crossing the midline. It is seen only over one side of the body. So, what is the name of this type of a vitiligo? Can you give some name for this type of vitiligo? So, this is called as segmental vitiligo. Can be a spotter for your exam. Can be an image spotter for your exam. So, this is called as segmental vitiligo, which do not cross the midline. Which do not cross the midline. Very good. So Suhadeep, Moideen, all of you who are answering it, excellent. You are on track. It is a very much a right answer. Okay. So before we go forward, just write down what is a drug of choice. So how do we treat the cases of vitiligo? So can you name any calcineurin inhibitors which can be used for the management of vitiligo? So the calcineurin inhibitors which can be used for the management of vitiligo is called as tacrolimus. Very good. Or pimecrolimus. So tacrolimus or pimecrolimus, these are the calcineurin inhibitors which can be used for the management of vitiligo. Okay. Very good. So Susanta, all of you are answering. Excellent. Okay, now let's move to the next question. A patient presents with multiple small cauliflower-like growths in the genital area. The lesions are painless and have a rough surface. Based on the clinical presentation, which of the following is the likely diagnosis? So I have no idea how many times this question has repeated in the FMG exam. So almost every exam you can expect a question from this topic. And what is this very important finding? Cauliflower-like lesions in the genitalia, easily movable. The lesions are not painful, it is painless, it has a rough surface. और क्या चाहिए, isn't it? So this is called excellent. All of you are able to answer. Mohiddin, Wasim, Nawab, Susanta, all of you. So this is called as condyloma acuminata. So on the day of the exam, if you get an image like this, which will show you there are multiple rough surfaced exophytic lesions over the genitalia, we call it as condyloma acuminata. Now, what is the causative of condyloma acuminata? So this is caused by human. So what is the causative? Yeah, it is caused by human papilloma virus. So what is a subtype which causes condyloma acuminata? It is caused due to 6 and 11. Okay? Are they high risk subtype or a low risk subtype? These are going to be low risk subtypes. So these are going to be low risk subtypes. So please don't make a mistake. Like if any of you is answering it as 16 and 18, don't worry right now. But remember that HPV 16 and 18, they are high risk subtypes. And this is actually implicated in cervical cancer. Cervical cancer. Okay? So, but don't make this mistake on the day of exam. So for exam, condyloma acuminata, remember it is caused due to HPV 6 and 11. दोनों low risk subtype है, इसीलिए it will not become a malignancy. This is not going to become malignancy. So malignancy कहाँ पे होता है? That is going to happen in cervical carcinoma because it is caused due to HPV 16 and 18. It is considered to be high risk. Now, what is condyloma lata? So a quick question: what is condyloma lata? So in which disease do we find condyloma lata? Any of you? All of you are able to answer. So just try to answer this one also. Lata is seen in syphilis. Okay, this is typically seen in secondary syphilis. It is called as condyloma lata. Flat topped lesions hota hai, that is seen over the genitalia. So this is called condyloma lata. Now remember, in the cases of condyloma acuminata, I just wanted to add one more point here. In condyloma acuminata, there is no role of antiviral agents in the treatment. Okay? So many antiviral agents that you know, like acyclovir, famciclovir, ganciclovir, etc. So none of these antiviral agents has a role in the management of condyloma acuminata. Okay? So condyloma acuminata. So what is our treatment of choice in condyloma acuminata? Any idea? So we can use some immunomodulators like imiquimod or podophyllins. So imiquimod or podophyllins, these are immunomodulators which can be used in the management of condyloma acuminata. Many other treatment modalities like cryotherapy, electrocautery, RF ablation, all these things can be done. But the treatment of choice can be immunomodulators, not antiviral agents. Okay, there is no role of antiviral agents in the treatment. That is the important point that you have to remember for your exam. So, next one. Which of the following pairs the clinical sign with the most likely associated dermatological condition? So, what are the options? Nikolsky sign, Auspitz sign, Koebner phenomenon. So, in case you get an MCQ like this, just in the level of the NEET PG, where you are asked 3 topics together. So, now what you will do is go step by step. Your approach should be first, if it is Nikolsky sign, just see in the MCQ what is a sign that you really know. Is it Nikolsky, is it Auspitz, or is it Koebner's phenomenon? Let us say that all of you know about Auspitz sign. Auspitz sign, where do you find Auspitz sign? It is seen in psoriasis. So here Auspitz sign is seen in psoriasis. That is right. Auspitz sign is seen in psoriasis. That is correct. Auspitz sign is seen in psoriasis. That is correct. So easily you can rule out this one because that is definitely wrong. So now we are left with 3 options. Now next one, let us try to see Nikolsky sign. Nikolsky sign, like you apply a tangential pressure over the skin and the skin will peel off. Where do you find Nikolsky sign? Nikolsky sign can be seen in pemphigus vulgaris, pemphigus foliaceus, staphylococcal scalded skin syndrome. Correct? So Nikolsky sign bullous pemphigoid. It is wrong. So this can be rolled out. Let's go to option number C. Nikolsky sign pemphigus vulgaris. Correct? And Koebner phenomenon lichen planus. Let us see option D. Nikolsky sign linear IgA disease. Bilkul nahi. That is wrong. So what is the right answer? This is going to be Nikolsky sign pemphigus vulgaris, Auspitz sign psoriasis, Koebner phenomenon lichen planus. See, why am I doing the MCQ in the same pattern how I will be giving the exam? Is because this is the way you have to approach the MCQ on the day of the exam. Okay? Go for the right one which you know very confidently and then go to the next one. I'm sure that you'll be able to reach out to the correct answer. Okay? So now let us quickly revise all the important signs that you have learned in dermatology. So what are the very important signs that you have learned in dermatology? First one, Hutchinson sign. I'll give you a clue. There is a vesicle at the tip of my nose. Now what does it mean when it comes to herpes zoster? So what involvement? Is it my ear involvement or my eyes involvement? Obviously, that is going to be eye involvement. So Hutchinson sign is seen in herpes zoster ophthalmicus. It is seen in herpes zoster ophthalmicus. Now, where do you find Darrier sign? Any idea where do you find a Darrier sign? Darrier sign is not seen in Darrier's disease, correct? But where is Darrier sign seen? Darrier sign is seen in urticaria pigmentosa. So Darrier sign is seen in urticaria pigmentosa. Third one, excellent. All of you are answering very good. Now where do you find Auspitz sign? Ab ye to sabko pata hai, isn't it? We just did it in the MCQ. This is seen in psoriasis. Auspitz sign is seen in psoriasis. So what about the next one? Koebner phenomenon. So Koebner phenomenon, there is an easy mnemonic which we have learned, isn't it? So that is called LVP. What is L? L is for lichen, V for vitiligo, and P for psoriasis. And P for psoriasis. Where do you find Nikolsky sign? Nikolsky sign is seen in pemphigus vulgaris, pemphigus foliaceus, and there is one infection that is called staphylococcal scalded skin syndrome. Very good. LVP. And now here Nikolsky, pemphigus vulgaris, pemphigus foliaceus, and staphylococcal scalded skin syndrome. Asbo-Hansen sign. Now there is a bulla and we are trying to move the bulla either by perpendicular pressure or by a pressure sideways. So what is this bulla spread sign? Ya fir Asbo-Hansen sign. Where is it clearly demonstrated? It can be demonstrated in bullous pemphigoid. Can be demonstrated in bullous pemphigoid. To some extent, it can also be demonstrated in pemphigus vulgaris as well. Now, who can answer where do you find a Fitzpatrick sign? Any one of you in the chat box, please. Fitzpatrick sign. So, Fitzpatrick sign, it can be seen, yeah, in a condition called as dermatofibroma. Dermatofibroma. So Fitzpatrick sign is also called as dimple sign. It is also called as dimple sign. Finally, Gottran's papules. So all of you must be knowing that there is a disease which affects the muscles as well as the skin, where the patient can present with violaceous papules over the joints, over the knuckles, interphalangeal joints. What are those? Gottran's papules seen in? Yes, Avanish Mishra is answering it right. This is called as dermatomyositis. Dermatomyositis. So what is your task? Is to go back today and revise all the clinical signs that is important in dermatology, because all these things whichever I've given you in a table are very, very, very important topics. Okay? So now let's move to the next one. Very good, Mohiddin. You're also answering it right. So now let's move to the next one. A 30-year-old patient presents with painful genital ulcers and inguinal lymphadenopathy. Ulcers are deep with a purulent base and sharply defined borders. Patient denies any upper respiratory symptoms or eye problems. Which of the following is the most likely cause of these ulcers? Any guess? Again, when it comes to genital ulcer disease, a repeated question, important topic, है ना? So every time you get a genital ulcer disease, I always tell you in my classes that you always will have to differentiate between painful genital ulcer and a painless genital ulcer. So try to remember painless genital ulcer with the name of a drug, that is LSD. Okay. So if you take a drug, you may not get to know the pain. So that is a key. So what are these LSD stands for? L stands for LGV, L stands for LGV, S stands for syphilis, and D stands for donovanosis. And trust me, in most of the MCQs, clinical MCQs that is being asked, if there is in the question, if it is mentioned, patient presents with painless genital ulcer or a painful genital ulcer, you will be able to rule out at least one option if you remember this thing right, LSD. Now let's see, patient presents with a painful genital ulcer. Okay, and we are not reading any other question. Painful matlab it cannot be LGV, it cannot be S stands for syphilis, and it cannot be D stands for donovanosis. So what is the straight away right answer that we are getting here? That is going to be chancroid. That is going to be chancroid. Okay. So now when we just try to memorize all of the important points of various genital ulcer disease, so please make a note of this one. Very, very important thing, that in syphilis, what is the type of genital ulcer and what is the type of lymphadenopathy? So in syphilis, do we get a painful or a painless? This is going to be painless ulcer. Plus, it is going to be painless lymphadenopathy. मतलब syphilis is going to be a completely a silent disease. Ulcer में कोई pain नहीं है. Okay, lymphadenopathy में भी there is no pain. So painless ulcer, painless lymphadenopathy. Going to the next one, chancroid. Chancroid, painful or painless? सिर्फ LSD is painless. मतलब chancroid is going to be painful ulcer and painful buboes. Okay, remember, it is going to be buboes. Buboes means that the lymph node is going to contain pus. So suppurative lymphadenopathy is going to be painful ulcer plus painful buboes can be seen in chancroid. Okay? Next one, LGV. So in LSD, L stands for LGV. So again, this is going to be painless ulcer. So along with that, you can get a painful buboes. So what are the two diseases where we can find a bubo? So bubo can be seen in chancroid as well as in LGV. Okay, chancroid and LGV you can find buboes, but chancroid ulcer is painful, LGV ulcer is painless. अभी donovanosis में क्या हो रहा है? So LSD, D stands for donovanosis, again painless ulcer, isn't it? It looks beefy red in color. Okay, beefy red in color. That is happening in donovanosis. And in donovanosis, please try to remember that there is no lymph node involvement. There is no lymph node involvement. Next one is herpes genitalis, which is the most common type of genital ulcer. So what is the most common? You can always be asked, है ना? So herpes genitalis में क्या होता है? So in herpes genitalis, you can find a painful ulcer plus painful lymphadenopathy. I did not use the word bubo. That is a catch here. क्योंकि bubo मैंने use किया था chancroid और LGV में, पर in herpes genitalis there is just a painful lymph node. दोनों painful रहेगा, ulcer भी और lymph node भी, but this is not a bubo. I have added one more disease here, which is called as Behçet's disease. So in the chat box, can any one of you tell me what are the components of Behçet disease? Because this can also be easily asked for the FMGE exam. So in Behçet disease, So you get two types of ulcers and one involvement of the eye. That is a clue that I can give you. So remember, you get a recurrent genital ulcer. So along with that, yes, along with that, what is the other ulcer you can get? You can get aphthous ulcer, which means there can be ulcers within the oral cavity. So recurrent genital ulcer, recurrent aphthous ulcer, along with anterior uveitis. Okay, it can be anterior or posterior uveitis, but anterior is more common. So these are the components of Behçet disease. So again, a very important table, all genital ulcer disease. Please go back, have a quick reading, and make sure that you do not make anything wrong in this topic. Okay. So yes, so now let's go to the next one. A 25-year-old patient presents with a non-painful indurated ulcer on the genitalia. So once again, it's a genital ulcer disease MCQ. So the question says non-painful, which means which are the non-painful things. It can be L, S, and D. And a non-painful. So there is an indurated ulcer that resolved spontaneously few weeks ago. The patient now has a diffuse maculopapular rash, including on the palms and soles, and generalized lymphadenopathy. So which of the following is the most likely diagnosis? Now, which is that genital ulcer disease, which is not just limited as a genital ulcer, which can also show many other systemic symptoms, many other skin symptoms, hair symptoms, etc. Yeah, that is going to be syphilis. Now, if there is a patient who is having generalized lymphadenopathy, not only inguinal lymphadenopathy, and there are some rashes over the palms and soles or sometimes over the trunk. So what is it? Is it primary syphilis or secondary syphilis? Yes, this is going to be secondary syphilis. So please try to remember, by the time the patient reaches secondary syphilis, the patient will be having a generalized lymphadenopathy plus rashes, condyloma. Is it lata or acuminata? Yeah, condyloma lata. Remember? So rashes, condyloma lata, generalized lymphadenopathy. What is the type of hair loss? There is a type of alopecia in secondary syphilis that is called as moth-eaten alopecia. Moth-eaten alopecia. All these things can be seen when it comes to secondary syphilis. So in this option, primary syphilis is not the right answer, क्योंकि primary syphilis में सिर्फ genital ulcer होता है and inguinal lymphadenopathy होता है. और genital herpes, is it the right answer? No, because genital herpes is always going to be painful. So इसीलिए this is not the right answer. Chancroid is also going to be painful, so chancroid is also not the right answer. Okay? So that is a general approach to this MCQ, how you should be getting it right. So now let's move to the next one. A patient with a history of limited dietary variety, predominantly consuming corn-based products, presents with symmetric hyperpigmented scaly lesions on sun exposed area, matlab photosensitive rashes, chronic diarrhea, and recent onset of confusion. There is no history of alcohol abuse. Which of the following is the likely diagnosis? Pellagra, beriberi, scurvy, Wernicke-Korsakoff syndrome. Yeah. So have you noticed that in the FMGE exams, every time they are going to ask you this question about this disease. What is this disease? It is called as pellagra. Every MCQ, every FMGE exam. So remember, what is the main diet? They are usually going to be maize eaters. And in pellagra, the patient will present to you with multiple D's. D as in diarrhea, that is given in this MCQ itself, diarrhea. And the sun exposed areas with skin lesions is dermatitis, and confusion can be like dementia. In untreated cases, it can lead to death. So what is being deficient? Yeah, so this is going to be niacin deficiency. So there is going to be niacin deficiency here, and this is called as pellagra. The two very important image-based questions are these two. So what is this? This is photosensitive rash, which you can find in around the neck area. So what is this? This is called as some necklace. What is the name of this necklace? This necklace is called as Kezal's necklace. So this is called as Kezal's necklace. And what is this kind of a shiny rash that you see over the dorsum of the hands? So this kind of a shiny rash that you can see over the dorsum of the hands, these are called as gauntlet sign. These are called as gauntlet sign. So these two are very important image-based questions that can be asked when it comes to niacin deficiency or vitamin B3 deficiency, that is called as pellagra. Okay, that is called as pellagra. So what is that thing that is called as Wernicke-Korsakoff syndrome? यहाँ पे भी there is a deficiency of thiamine, isn't it? And that is seen in which type of patients? That is usually seen in patients who are going to be chronic alcoholics, isn't it? Chronic alcoholics. So in this MCQ, what is scurvy? Scurvy is going to be deficiency of dash. Yeah, scurvy is going to be deficiency of vitamin C. Correct? Where the patient can present to you with bleeding of the gums. Bleeding of the gums. So that's it. Very good. So now let's move to the next one. A 7-year-old infant presents with symmetric erythematous lesions around the mouth, hands, and diaper area, accompanied by alopecia and intermittent diarrhea. The infant was exclusively breastfed until 6 months of age and has shown these symptoms since transitioning to formula feeding. The blood test reveals a low ALP level. Which of the following conditions should be most strongly considered? Yes, what is the right answer here? So, long question once again. So what you have to do is you should be sharp enough to understand कि क्या हो रहा है इसमें. That is a 7-year-old is the infant's age. Up to 6 months, the baby was breastfed. And at that time, the patient did not have any symptom. When did the patient start showing symptom? After 6 months, while moving into 7 months, while moving to formula feeding, the patient started developing symptom. What were the symptoms? There was some rashes. There was alopecia and diarrhea. Now what comes to your mind? Yes. So Avnish and Muhiddin, all of you are answering it right. So this is going to be acrodermatitis enteropathica. So in acrodermatitis enteropathica, this is how a child can present to you. So these are rashes around the mouth area. है ना? So this is due to zinc deficiency. This is due to zinc deficiency. Usually happens when a child moves from exclusive breastfeeding to formula feeds, and the zinc deficiency becomes very obvious, and the patient can present to you with a mnemonic that is DAD. What is DAD? D stands for diarrhea, A stands for alopecia, and D stands for dermatitis. So diarrhea, alopecia, and dermatitis, these are the three types of symptoms that you can see in acrodermatitis enteropathica. It is caused due to zinc deficiency. Okay, so now let's move to the next one. A 45-year-old patient presents with oral ulcers and flaccid bulla on the trunk and the face. The bulla ruptures easily, leaving painful erosions. 𝐒𝐿𝐂𝐈𝐀 sign is positive. So a 45-year-old patient. So there are oral ulcers. Matlab, the symptoms are present within the oral mucosa. And what is the type of bulla? Is it tense or flaccid? It is going to be a flaccid bulla. And the bulla, since it is flaccid, it easily ruptures, leaving painful erosions. 𝐒𝐿𝐂𝐈𝐀 sign is positive. Histopathology shows suprabasal acantholysis, direct immunofluorescence, of the perilesional skin reveals intercellular deposits of IgG and C3. Which of the following is the most appropriate initial treatment? Now, given so many clues, tell me what is your diagnosis? There is a suprabasal split. IgG and C3 is present within the epidermis. So what is the answer? Yeah, this should be pemphigus vulgaris. So in pemphigus vulgaris, what is going to be our initial treatment? Are we going to use acyclovir, which is an antiviral? Obviously no. How about high potency topical steroids, creams? Is it enough? Because we are having severe painful lesions. No. So systemic corticosteroids or antibiotic therapy. So what is the most appropriate answer here? Yeah, the most appropriate answer would be systemic corticosteroids. We all know that steroids are the drug of choice when it comes to pemphigus group of diseases. So here the right answer is going to be systemic corticosteroids. Now, can you see these are very important images of pemphigus vulgaris. So in pemphigus vulgaris, what happens is there is a split that is happening to the skin just above the stratum basale. So there is a split in the stratum spinosum. So when there is a split in the stratum spinosum, what is happening? In the basal layer where there was multiple these kind of columnar keratinocytes, they get separated from each other and it look like this. What is this finding called as? When the basal keratinocytes, they get separated and they are arranged linearly like this, it looks like a row of tombstones. So this is called as row of tombstone appearance. This is called as row of tombstone appearance. Very important histopathological finding in pemphigus vulgaris. Okay. And now next one. What is this? We already had one of the MCQ based on the DIF findings already. So this is called as IgG and C3 deposits in a fishnet pattern. In a fishnet or chicken wire pattern. These are the very important two images that you can see in pemphigus group of diseases or especially in pemphigus vulgaris. In pemphigus vulgaris. Yes, very good. Now, as Muhiddin has reminded me in the chat box, now what happens in a Zang smear in pemphigus vulgaris? In the Zang smear, you can find these kind of rounded cells with a large nucleus. And what are these rounded cells with a large nucleus called as? These are called as acantholytic cells or Zang cells. Okay, or Zang cells. So these are called as acantholytic cells or Zang cells, which you can see in pemphigus vulgaris. So now let's move to the next question. A 19-year-old patient presents with severe nodulocystic acne, characterized by numerous deep inflamed nodules and cysts over the face, over the chest and the back. The patient reports significant scarring and psychological distress. Previous treatments included topical retinoid creams and antibiotics with limited success. What is the next appropriate step in management? So here we already know what is the diagnosis. Diagnosis is severe nodulocystic acne. Now acne vulgaris is another very important repeat MCQ topic for you for the FMGE exam. So please concentrate here. So in severe nodulocystic acne, what is your drug of choice? Is it oral isotretinoin? Is it topical benzyl peroxide and salicylic acid? Oral contraceptives or IPL therapy, that is intense pulse light therapy? So what is the right answer? Yeah. So when it comes to nodulocystic acne, our drug of choice is going to be oral isotretinoin. Okay, oral isotretinoin. So in severe acne, is going to be oral isotretinoin. So what is the organism that is implicated in acne? We discussed about it while we were talking about wood slam today. The organism is going to be Propionibacterium acne. So in all types of acne except severe acne, what is our drug of choice? It is going to be topical retinoids. Is going to be topical retinoids. But if it is severe acne, the answer is going to be oral retinoids. Now these kind of images are also very important. Now what is the first image? That is also a type of acne vulgaris. Now who can tell me what is that type of acne vulgaris that you can see in the first image? Can you see multiple black spots? So what are these called as? These are called as blackheads. So these blackheads are also called as open comedones. These are called as open comedones. Whereas if it appears completely white, these are called as whiteheads or closed comedones. So dear students, remember that for your exam, if there is this magical word of comedones, there is only one disease which can show you comedones. The answer is definitely going to be acne vulgaris. It is going to be acne vulgaris. So whoever is answering it right, excellent, good going. So I'm sure that your preparations are on track. And please remember, it's a repeat topic, that is acne. Be it whiteheads, blackheads, nodulocystic acne, papillopustular acne, all these things you should be able to pick up. Remember, in every cases, our drug of choice is going to be topical retinoids. In severe cases, our drug of choice is going to be oral isotretinoin. And the organism that is implicated is Propionibacterium acne. Okay. Yeah. Going to the next one. A 40-year-old patient presents with a rapidly enlarging, painful ulcer on the lower leg. The ulcer has a violaceous border and an undermined edge. The patient has a history of ulcerative colitis. Biopsy of the ulcer edge shows neutrophilic infiltration, but no evidence of infection. See, once I'm reading like this, it is like even I'm not able to get the right answer, correct? But if you just concentrate on these kind of long MCQs and just try to pick up the key points. So now let's go in order. Age, it may be relevant, 40-year ka patient hai. Now there is a painful ulcer. Now is it genital ulcer? No, it is an ulcer in the lower leg. So 40-year ka patient who is having an ulcer in the lower leg, and he is also having a history of ulcerative colitis. And once you did a biopsy, you can see that there is neutrophilic infiltration. So here, this is more likely to be a neutrophilic dermatosis, which presents with a non-healing ulcer of the lower leg, which may be associated with ulcerative colitis. Now, what comes to your mind? Is it venous stasis ulcer? Did I talk about varicose veins? No. So pyoderma gangrenosum, just keep it on hold. Cutaneous vasculitis, not likely. Necrotizing fasciitis is an infection, but there is no fever or anything mentioned, less likely. So the answer should be pyoderma gangrenosum. So there is no gangrene here because this name is a misnomer. There is no gangrene here because this name is a misnomer. Okay? So this is the disease where the patient can present with a non-healing ulcer. And there are some disease associations. And because this is associated with irritable bowel disease like ulcerative colitis. It can be associated with rheumatoid arthritis. Or it can be associated with hematological malignancy. Or it can be associated with hematological malignancy. So these are the important associations of this condition called pyoderma gangrenosum, where it is considered to be a neutrophilic dermatosis. Okay, it is considered to be neutrophilic dermatosis. And yes, within rheumatoid arthritis also, and you can treat the patient with steroids. Moving to the next question, a 7-year-old child with a history of atopic dermatitis. Now, already atopic dermatitis का history दिया हुआ है, and with a rapidly expanding erythematous lesion on the cheek, featuring central yellowish crusting. There is some yellow colored crust. So the child is not having any fever and is otherwise healthy. But a culture from this lesion where there is some yellowish crust, this culture is growing Streptococcus pyogenes. What is the likely diagnosis? Can anybody answer what is the likely diagnosis here? So the likely diagnosis here, yeah, is it eczema herpeticum, non-bullous impetigo, bullous impetigo, or perioral dermatitis? Yes, golden yellow honey colored crust. Golden yellow honey colored crust. So where did we learn about a golden yellow honey colored crust? It was in impetigo, that too in non-bullous impetigo. What was the causative of a non-bullous impetigo? The non-bullous impetigo was usually caused due to streptococcus, and this is how an image may look like. A patient may develop multiple small vesicular rashes, and this rashes may erode to form a golden yellow honey colored crust. So if you just send a small swab for culture, the culture can be either positive for a streptococcus or it can be positive for staphylococcus. But for non-bullous impetigo, most common organism is streptococcus. For bullous impetigo, the most common organism is going to be Staph aureus. Okay. Now, why is there a history of atopic dermatitis given? Is it just trying to, make you answer something like eczema herpeticum? See, in atopic dermatitis, क्या होता है? There is a child with a itchy skin. So whenever you repeatedly itch, what happens? There is a chance for a super added infection. Usually it can be a bacterial infection. Okay? And whenever there is a viral infection, in the cases of atopic dermatitis, we can call it as eczema herpeticum, which can be caused due to herpes simplex virus. Okay? But here, because of the yellow colored crust, the answer, along with the presence of streptococcus pyogenes, the right answer here would be non-bullous kind of an impetigo. So moving to the next one, a patient with a non-diagnosis of leprosy suddenly presents with a onset of tender nodules. See, there is a leprosy patient, there is a erythematous tender nodules on the skin, along with systemic symptoms like fever and malaise. Patient is currently taking multi-drug therapy for leprosy. Which of the following is the most likely cause of these symptoms? So can you just try to give an answer? Is it type 1 reaction, type 2 reaction, allergic reaction to the multi-drug therapy, or is it the progression of leprosy? So remember, anytime the patient of leprosy, a patient of leprosy usually on treatment may present to you with complaints of redness and inflammation of existing skin lesions, So this one is called type 1 lepra reaction. Whereas if a patient of leprosy may present to you with tender nodules over the shin along with systemic symptoms, this is called type 2 lepra reaction. Okay? So any patient of leprosy, you can expect two kinds of reaction. One is type 1 lepra reaction. The other one is type 2 lepra reaction. What happens in type 1 lepra reaction? That the patient will have some hypopigmented patches which become red and swollen because of inflammation. The second one is going to be the patient can present to you with the tender subcutaneous nodules over the shin along with systemic symptoms, and this is called as type 2 lepra reaction. So in this case, what happens is that the patient is having leprosy. There is tender nodules over the skin. What is the right answer going to be? This is going to be type 2 or erythema nodosum leprosum reaction. And remember, lepra reaction is not a drug reaction. It is not a drug reaction. Now, quickly tell me, what is a drug of choice, be it type 1 or type 2 lepra reaction? What is the drug of choice? This can also be asked. The correct answer is this is going to be prednisolone. Systemic steroids or prednisolone is going to be the drug of choice of lepra reaction. Yes, Avnish, type 1 is type 4 hypersensitivity and type 2 is type 3 hypersensitivity. Excellent. So now let's see the next one. A 55-year-old patient presents with a unilateral vesicular rash affecting the ophthalmic division of the trigeminal nerve. So trigeminal nerve, the ophthalmic division is going to be affected, and the patient is having a unilateral, which means there is only one side, vesicular rash, and the patient is complaining of severe pain, photophobia, and decrease in vision in the affected eye. What is the likely diagnosis? Yeah, can you just tell me what is the likely diagnosis here? Patient को unilateral lesion है, it is going to be vesicular lesions and there is severe pain. That is going to be herpes zoster, correct? So herpes zoster ophthalmicus. Herpes zoster ophthalmicus. So today during the course of our discussion, we told about one sign. What is that sign? Vesicle at the tip of the nose implies there is an involvement of the eye, that is called as Hutchinson sign. So this topic called herpes zoster या फिर chicken pox, commonly asked question for your FMGE exam. So any type of these image based questions, whenever you see this kind of a lesion, always try to imagine that this is a lesion which do not cross the midline. So this is probably along a dermatome and this is going to be herpes zoster. And you can see that in this child also it is over the face or doesn't cross the midline, and this there is a high chance of affecting the eyes as well. So this can be herpes zoster ophthalmicus. Yeah, this is going to be herpes zoster ophthalmicus. So what is the treatment in herpes zoster? The treatment here would be acyclovir. This is also asked in FMG exam. So along with acyclovir, what is the other symptom that you would like to take care of? You would like to take care of the chronic persistent burning pain. So along with that, you can also give gabapentin. So why do we give gabapentin along with it? To take care of post-herpetic neuralgia. So to take care of post-herpetic neuralgia, we also give gabapentin. So now let's see the next MCQ. A 30-year-old patient presents with a sudden onset of raised pruritic well-defined wheals on various parts of the body. So what is the primary skin lesion that is mentioned? Wheals. So all of you, when you read the MCQ itself, try to catch the main important points. There is 30-year-old and the patient denies any recent insect bite or new medication, which means it is not due to drug induced or not due to any hypersensitivity after an insect bite. So shortly after, the patient develops the swelling of the lips and the periorbital area. So along with the wheals, there is swelling of the lips and the periorbital area, and there is no associated respiratory distress or hypotension. What is the answer here? What is the diagnosis? Is it urticaria and angioedema due to allergic reaction? Or is it urticaria and angioedema due to hereditary angioedema? Is it eczema or cellulitis? So obviously in cellulitis and in eczema, we never discussed about having a wheal and angioedema, correct? So it should be urticaria and angioedema, but is it due to allergy or is it due to hereditary angioedema? No, here I would rather go for the answer A than B, because what happens in hereditary angioedema? What is the defect in hereditary angioedema? Yeah, there is going to be C1 esterase inhibitor defect. Okay, there is a defect of C1 esterase inhibitor defect. So usually hereditary angioedema, what is the clinical presentation? The patient will have angioedema without urticaria. Angioedema without urticaria. Then think about hereditary angioedema. So here this is more likely because of some allergic reaction. And what are these images? These are the images which can be asked. So these are some edematous lesions that you can see over the skin, and this is called as wheals, which we commonly see in urticaria. Usually within what time frame does a wheal disappear? So these usually disappear within 24 hours. Within 24 hours. And whenever you get this kind of a swelling over the lips or around the periorbital area, then what do we call it as? We call it as angioedema. We call it as angioedema. So these are some of the image spotters for you. And in all the cases of wheals, urticaria, angioedema, what is our treatment of choice? Our treatment of choice is going to be antihistamines. Antihistamines. But whenever the patient is developing angioedema, there is a fear that the patient may complain of breathing difficulty. There may be a chances of sudden fall in BP, so increase in pulse rate. So if there is no respiratory distress or hypotension, we know that the patient is not having anaphylaxis. Okay, anaphylactic shock or anaphylaxis. That is why there is a mention about respiratory distress as well as hypotension in the MCQ. That is all about this MCQ. So now let's go to the next one. I hope things are clear, all of you. So we are going to the next MCQ now. A 60-year-old patient presents with a slowly enlarging pearly papule on the nose, which has a central ulceration and telangiectasia. Patient has a history of frequent sun exposure. On examination, there is no regional lymphadenopathy. What is the most likely diagnosis? So quickly, all of you who are listening to this lecture, can you please give me an answer? Is it basal cell carcinoma, squamous cell carcinoma, malignant melanoma, or actinic keratosis? Yeah. So here, the question says that a patient is having a papular lesion with a central ulceration and telangiectasia. Typical presentation of basal cell carcinoma. What is the most common site where you can find a basal cell carcinoma? It is over the face. Okay. And how does basal cell carcinoma look like? Very good, Mohiddin. It looks something like this. It usually has a rolled up border, or it can be a nodule. Sometimes it can be pigmented. In the center, if you see, there can be telangiectasia also. So this is a typical presentation of basal cell carcinoma. About this one, what is this? If I tell you that this is another malignancy where a patient presents to you with a black mole which has recently increased in size and changed its color, and there is an asymmetric border and there is some color variation, etc. Now what comes to your mind? Yeah. So this is going to be called as malignant melanoma. It is going to be called as malignant melanoma. Now, what is the algorithm which we usually assess malignant melanoma? It is going to be the ABCDE algorithm, correct? So what is A? A stands for asymmetry, B stands for border irregularity, C stands for color variability, D is diameter more than 0.6 mm, and E is that it is going to be changing in its color, shape and size. Now, when coming back to this MCQ, where they asked about basal cell carcinoma, if there is a basal cell carcinoma that destroys the tissues underneath, so what do we call? We call it as some ulcer. What is this ulcer? This is called as rodent ulcer, also called as the rodent ulcer. Okay, so that is about basal cell carcinoma. Now moving to the next one, a 45-year-old patient presents with a dark, thickened, velvety skin in the axillary and neck regions. The patient reports no itching or discomfort. There is no family history of skin changes. What is the likely diagnosis? So any guess? Is it acanthosis nigricans? Is it seborrheic keratosis, dermatofibroma, or verruca vulgaris, common warts? See, whenever a patient is going to develop this kind of a dark, thickened, velvety skin, especially over the back of the neck or in the axilla, so these are the common areas. That is going to be acanthosis nigricans. So now let us see one of the image of acanthosis nigricans. It's a commonly asked question for the FMGE exam. So here you can see that there is some hyperpigmentation. There is some velvety texture of the skin, isn't it? So this is called as acanthosis nigricans. Now what are the common associations of this condition? So acanthosis nigricans, the common association is going to be obesity, the most common association. Along with obesity, it can be metabolic syndromes. So it can be metabolic syndromes like diabetes mellitus, obesity, weight gain, all these things will come under metabolic syndromes. It can sometimes be seen in PCOS, polycystic ovarian syndrome, isn't it? So these are the multiple associations. Rarely it can also be associated with malignancies also. So rarely it can be associated with malignancies as well. So this is called as acanthosis nigricans. It's called as acanthosis nigricans. So that is about the velvety texture of the skin. Okay. So I think that is it. With that, we are coming towards the end of our session. So there is a small change in schedule because Santosh sir will be doing medicine tomorrow, that is on 7th of January. So I hope that all the sessions were pretty much useful to all of you. So please keep going. Very few days left for your exams. Just try to go through all these important topics, important MCQs, and stay very, very positive because the exam is not going to be that tough. You will be able to answer. To score 150 is very much possible with the kind of effort that all of you are giving all these days. Okay? So just keep going, stay positive, practice more MCQs, try to memorize the most important points from all your notes, and then I'm sure that you'll be able to crack the exam this time. So we all will keep in touch. And once again, I wish you all the very best and keep rocking. Thank you so much.